Hello everyone. Let us now discuss bacterial infections in children. Now there are innumerable bacterial infections, but from pediatrics point of view, around 5 to 6 infections are the ones which are important, not read properly but often asked in exams. The first and the most important bacterial infection we'll be discussing is diphtheria. Diphtheria, as you already know, the causative agent or etiological agent is a gram-positive organism called as Corynebacterium diphtheriae. So first of all, what is the etiological agent? It is a gram-positive bacillus known as Corynebacterium diphtheriae. What is the source of infection? The source of infection in diphtheria is either a case or a carrier. Carriers in diphtheria do tend to exist, and the most common mode of infection is through the droplet route. So, droplet route is the common source of infection through which diphtheria can spread. Now, coming to pathogenesis of diphtheria. When we talk about diphtheria pathogenesis, remember that the most important pathogenetic factor is a exotoxin produced by bacteria. That exotoxin has a tendency to inhibit protein synthesis as well as cause necrosis of epithelial cells. In addition, that toxin can spread through the blood and it can affect various organ systems like heart, kidney and the nervous system. So, pathogenesis relates to the production of exotoxin by the bacteria. This exotoxin, the ability to produce exotoxin is not inherently present in the bacteria, it is an acquired thing. The ability to produce this exotoxin is acquired by a process called as lysogenic phage conversion. Lysogenic bacteria carrying the gene for toxin production are called as Tox plus strains. They can transfer the gene to relatively non-pathogenic or less pathogenic strains, and when these strains of Corynebacterium diphtheriae, they acquire this gene, they develop the ability to produce exotoxin. So, this exotoxin has a tendency to cause inhibition of protein synthesis. So, this inhibits your protein synthesis. By inhibiting protein synthesis, it performs three functions. First of all, it causes necrosis of the epithelial cells. Secondly, it produces a serosanguinous discharge associated with inflammation wherever it locally gets deposited, wherever this is considered to be a local action of this. And then through systemic action, this exotoxin can also produce systemic toxicity affecting various organ systems. That diphtherial exotoxin inhibits protein synthesis is an MCQ already asked in, you will find this question being asked in microbiology. Since we are discussing topics in a holistic, applied, integrated manner, so whatever MCQ relevant to our discussion will be coming, I will be marking it there. So, after talking about this pathogenesis, let us focus our attention to the clinical features of the disease. So, what happens in clinical features? First thing that you need to know is regarding the incubation period. The incubation period of diphtheria is 2 to 5 days. Again, MCQ asked in NEET PG exam in the past. If somebody asks you what is the earliest sign, the early sign of diphtheria is severe sore throat. It produces a severe kind of sore throat. So, it is a very, sore throat can be produced by viral infections as well as group A streptococcus. So, it is a very non-specific but a early sign. Following sore throat, there are three types of infections which tend to develop. So, broadly speaking, there are three types of diphtheria which we encounter. The first common type of diphtheria that is seen in children is called as phoceal diphtheria. Phoceal diphtheria is also called as pharyngeal diphtheria. It is also called as tonsillopharyngeal because it involves the tonsils and the tonsillar pillars. Phoceal or pharyngeal or pharyngotonsillar is considered to be the most common variety. The second common form of diphtheria is the nasal diphtheria, and the third common form is the laryngeal diphtheria. So, these are the three common types. There are other rare subtypes which have also been described, but they are not relevant and they are not often seen in case of children. Now, children who have this phoceal diphtheria, what are the features that they tend to develop? In phoceal or pharyngeal diphtheria, there will be fever present in only 50% of the cases. They will have sore throat, they will have a muffled voice, and many of them tend to develop edema locally, leading to dysphagia. But the hallmark of the disease is a pseudomembrane formation. There is a formation of a gray-white adherent pseudomembrane. This pseudomembrane is considered to be the hallmark of the disease. It is composed of a mixture of epithelial cells, fibrin, WBCs, some RBCs, some necrotic debris, and it is teeming with organisms as well. This pseudomembrane forms initially on the tonsillar pillars and then spreads to the local structures, that is adjacent structures. It spreads to uvula as well as the posterior pharyngeal wall. This is a very useful point from entrance point of view. There are other pseudomembranes which do tend to form, but they do not have a tendency to spread to adjacent tissues. This forming starting with the tonsillar pillar and then spreading to adjacent tissues is a useful sign, it is a useful clue for diphtheria being the likely diagnosis. Other than this hallmark, there is another characteristic feature that we find in these children. That feature is called as bull neck appearance. Bull neck appearance in diphtheria is seen due to the development of enlarged lymph nodes as well as local edema. So, what are the keywords that you should remember? Sore throat, febrile illness, pseudomembrane, bull neck appearance. 2 or 3 of these if they are present, you will always think of phoceal diphtheria or simply diphtheria as the likely diagnosis. So, focus on these keywords, and as the disease progresses, with progression, the patient may develop progressive respiratory obstruction, and sometimes due to the effect of toxin locally as well as on the cranial nerves, you will find soft palate paralysis also to develop. So, these are the features seen in the common variety, that is phoceal or pharyngeal diphtheria. Then we have the nasal diphtheria. Nasal diphtheria, the key words that you need to remember is there is unilateral or bilateral serosanguinous discharge, or simply you can write nasal discharge. So, unilateral or bilateral nasal discharge, plus it is associated with, I am writing with a different colored pen, ulcers are present on the nasal tip as well as the upper lip. So, this is the second form, that is nasal diphtheria. Third is laryngeal diphtheria, which is relatively rare but can be dangerous because membrane formation, edema, inflammation, infection can be localized to the larynx. So, children with laryngeal diphtheria will have prominent brassy cough, they will have stridor, fever will be plus or minus, it may or may not be present, and they will develop progressive respiratory obstruction. So, these are the 3 common types of diphtheria which have been described. Now, moving over to the complications of diphtheria. So, what are the complications that you need to remember? Firstly, that most common, if the question asks you what is the most common complication of diphtheria, the most common complication of diphtheria is respiratory complications. Among respiratory, it is respiratory failure due to obstruction of the respiratory passage. That is considered to be the most common. However, remember that it is the second most common cause of death. Overall complication सबसे common क्या है? It is respiratory failure due to obstruction, right? But it is not the most common cause of death, it is the second most common cause of death. This obstruction can occur due to pseudomembrane as well as local edema formation. The most common cause of death in diphtheria is a complication called as toxic cardiomyopathy. So, cardiac involvement due to the effect of toxins is the most common cause of death. It is MCQ point. This is MCQ, this is MCQ, please mark it. So, most common cause of death is toxic cardiomyopathy. It is also called as, it tends to overlap with features of myocarditis. So, sometimes it is also written as cardiomyopathy myocarditis syndrome due to diphtheria, right. So, when the children with toxic cardiomyopathy will develop, when would you suspect there is toxic cardiomyopathy? These children will have sinus tachycardia out of proportion to the grade of fever. They will also have S3 gallop rhythm and they may develop arrhythmias which can lead to sudden death. Toxic cardiomyopathy does not develop immediately, it usually tends to develop between second to third week of illness. Although it has been described in the first week also, it has been described in the 5th or 6th week also. But this is the time during which toxic cardiomyopathy tends to develop. What are the other complications that you should remember? So, other complications, first of all, we have the neurological complications. In neurological complications, the patient may develop palatal paralysis or palatal palsy, which tends to develop in the second week. Children who develop palatal paralysis will have nasal twang in voice and they may also show regurgitation and sometimes aspiration like features can develop. Then many of these children will develop ocular palsy, where extraocular muscles may be paralyzed. This tends to develop between 3rd to 5th week. Ghai gives a single value of 3rd week, whereas Nelson and CDT Pediatrics talk about a range of 3rd to 5th week. So, we have to go by standard books. 3rd to 5th week is the better answer here. And then we have a complication called as polyneuritis. This polyneuritis can produce a Guillain-Barré syndrome like illness. So, there can be a symmetric ascending paralysis very similar to Guillain-Barré syndrome, and this tends to develop in the 3rd to 6th week. And finally, we have renal complication due to the effect of toxin. All these complications are mostly toxin mediated except respiratory one, which is occurring due to pseudomembrane. That is, yes, it is related to toxin, but not a toxic manifestation. It is more of a pseudomembrane related manifestation, whereas others are the direct effects of toxins acting internally without any visible prominent pathological sign. So, renal manifestations will include features like oliguria and with or without proteinuria, but it is seldom the cause of death. Now, coming to the diagnosis of diphtheria. How do you diagnose? You can take a swab or you can take pseudomembrane and subject it to gram staining or a special stain known as Albert stain. So, if MCQ asks you Albert stain is used for which organism? It is used for Corynebacterium diphtheria, and culture is considered to be the gold standard investigation. Now, coming to the therapy of diphtheria, treatment. For the purpose of treatment, remember that you do give antimicrobials, but the most important agent is giving antitoxin to neutralize the toxin which is already in the system. You should not wait for the definite diagnosis or culture report to come. If there is a strong clinical suspicion or a history of contact with a diphtheria case or carrier, you should immediately go in for antitoxin administration. So, the most important component of therapy in diphtheria is administration of antitoxin. So, antitoxin therapy is considered to be the most important. It should be given ASAP. ASAP means as soon as possible. So, diphtheria antitoxin should be given. Along with that, plus you will also start the patient on antibiotics. Antibiotics are needed because diphtheria has a tendency to proliferate in the tissues. Diphtheria giving antibiotics will eradicate the focus and will also result in decrease in the toxin production. So, to decrease the toxin production and ongoing inflammation, you need to give antibiotics as well. So, you can use either beta-lactams like penicillin G or macrolide like erythromycin, which are considered to be the first line therapy. In case the patient is penicillin allergic or it is a severe infection, studies have shown that clindamycin is also useful. Clindamycin has a strong toxin inhibitory action. Plus these patients, because they are susceptible, so then you need to put them on DPT vaccination as well if it has not been given so far. So, DPT vaccination will also be given. And potential MCQ, I am putting a star, MCQ Pearl. What is the time for which the patient should be isolated? So, period of isolation in diphtheria. The period of isolation in diphtheria will be till 2 successive cultures are sterile. What it means? See, usually this penicillin or erythromycin are given for a period of 7 to 10 days. After completion of antibiotic course, we do culture, and these cultures are taken at least 24 hours apart. 2 cultures are sent. If both the cultures are negative after completion of antibiotic therapy, the patient can come out of isolation. He is presumed to be non-infectious. Otherwise, the patient continues to be infectious and a risk for transmitting the infection to household contacts. So, this is something that you must remember. Now, question may ask, a patient of diphtheria, clinical scenario, patient of diphtheria given this penicillin G, he was given antitoxin, managed properly, given penicillin G for 7 days. After completion of antibiotic therapy, the culture was still positive. What next will you do? Now, this is something you will not find in textbooks written directly. It is based upon the protocols. But for MCQs, scenario-based MCQs, this is important. And so, if the culture is found to be still positive for the organism, you should first change the antibiotic and give another complete antibiotic course for 10 days, and till the 2 successive cultures are negative, you should not presume the patient to be completely free from organism. So, this is something that you must remember. Now, there is a controversial and important thing in diphtheria regarding the prophylaxis of asymptomatic contacts with diphtheria. In NEET PG 2020, there was a controversial question upon that. The question was something like this: proven case of diphtheria is managed. There is a household contact of a child who has been immunized certain amount of days back. So, what therapy should be given to that child? So, the topic we will be discussing in this is how do you do prophylaxis? Prophylaxis for household contacts of diphtheria. So, there are 2 important things that you should remember. Any household contact, antibiotic prophylaxis is mandatory. This is the first thing you should remember. So, antibiotics is mandatory. Dena hi dena hai, irrespective of immunization status. You can give either benzathine, penicillin G, single dose 6 lakh unit intramuscular. So, you can give single dose of benzathine, penicillin G, or you can give erythromycin in a dose of around 50 mg per kg body weight per day in divided doses for 10 days. So, antibiotic prophylaxis has to be given, right? Then, along with this, diphtheria toxoid vaccine should be given in all immunized individuals who have not received a dose of this toxoid in last 5 years. And those who have received less than 3 doses of primary, you need to continue with the primary vaccination of diphtheria. So, primary DPT series needs to be completed. So, if the patient has received any booster in the last 5 years, then it is fine only antimicrobial prophylaxis is good enough. But if the patient has not received a diphtheria toxoid, say the last diphtheria toxoid vaccine was taken 7 years back, so you will give one booster dose of diphtheria toxoid and antimicrobial prophylaxis in these contexts. This is extremely important, and MCQ asked, very controversial question it was asked. And before we finish this topic, we'll write down some MCQ pearls taken from standard books, high likelihood of being asked. First of all, remember that toxic cardiomyopathy in diphtheria tends to occur in 10 to 25% of patients with respiratory diphtheria, okay, among those with respiratory involvement, phoceal or laryngeal or nasal, and is responsible for 50 to 65% of the deaths. So that is why it is considered to be the most common cause of death in diphtheria. Second is severity of cardiac toxicity of or myonecrosis in the heart is directly correlated with elevation of serum aspartate transaminase. So if serum aspartate transaminase is highly elevated, it indicates severe myonecrosis occurring in the heart. And thirdly, there is no role of corticosteroids in the toxin mediated complications. So these are the 3 points that you should remember. This finishes the topic of diphtheria in our discussion. The next bacteria we will be discussing is pertussis. Pertussis is also called as whooping cough. It is also called as 100-day cough. So these are the two alternative names. Which is the better term? Pertussis term is better because pertussis literally means violent cough, which is always present in these children. Whooping cough is not an accurate description because not all patients will have whoop, and in fact patients who have the most severe illness, that is infants, they very seldom have a whoop. So whooping cough word has been out of the literature now. 100-day cough was the old name for this, originated in China. When the antimicrobials were not there, patient will continue to have low grade cough for many days, and sometimes many patients will develop habitual coughers. And so the cough will continue for more than 3 months. So it was called as 100-day cough. The term 100-day cough is not applicable these days, but still from entrance point of view, this is something that you should remember. In your vivas, in your practicals, in the next 2 exam, which will be a viva based, you may be asked why it is called as a 100-day cough. So 100-day cough, I have told you the reason. So let us begin with the discussion. First of all, I will be following the same procedure, only discussing the relevant points. Etiological agent. Pertussis is caused by a gram-negative bacteria. So it is a gram-negative, not gram-positive, it is gram-negative bacteria. 90% cases, 85 to 90% cases are caused by organism called as Bordetella pertussis. Very rarely, sometimes it can also be caused by Bordetella parapertussis. But for all practical reasons, this is the organism that is the most common. It is a very, very infectious condition with the secondary attack rate of as high as 100%. Potential MCQ. Which of the following is considered to be the most infectious condition? It is considered to be the most infectious condition in children. What is the source of or mode of infection? The mode of infection is droplet route. So close contact as well as all these droplet precautions should be taken to prevent. Now coming to pathogenesis. In pathogenesis, this Bordetella pertussis produces many types of toxins. Among these toxins, the most important toxin which is involved in pathogenicity is a toxin called as PT. PT stands for pertussis toxin. This pertussis toxin helps the bacteria in attachment to epithelial surface, as well as it inhibits phagocytic function. Other important toxins which the bacteria produces, they include pertectin, filamentous, hemagglutinin. Why am I summarizing these? Because questions have been asked regarding the important toxins produced by pertussis. They can produce adenylate cyclase toxin. They can produce tracheal cytotoxic toxin, or simply called as tracheal cytotoxin TCT, and finally there is a dermonecrotic toxin. So these are the important toxins. In fact, pertussis produces 14 types of toxins, but these are considered to be the most important one, and these are the ones which have been asked in entrance exam. Now let us move towards the clinical features of the disease. First of all, what is the incubation period? Incubation period of pertussis is 7 to 14 days. Whenever a patient develops pertussis, there are 3 clinical stages which are described. The first clinical stage is called as the catarrhal phase. Catarrhal phase is considered to be the most infectious stage. So, potential MCQ, most infectious stage is catarrhal phase. This is the stage during which the patient will transmit to other children, other patients very easily. Catarrhal phase is strangely a very non-specific stage. Here there will be URI like features including cough, coryza and malaise. So they can happen in any other illness as well. Fever is usually absent. So fever is mild or absent. Catarrhal phase usually tends to last approximately 1 to 2 weeks. So catarrhal phase lasts 1 to 2 weeks. The second phase after 1 to 2 weeks are over is the paroxysmal phase, also called paroxysmal stage. This is the phase, or this is the stage during which the characteristic coughing happens. Now what is the characteristic of whooping cough, pertussis? It is the cough. There are episodes of violent cough in the child in which the child coughs repeatedly without taking any break, and then to catch his breath he takes a deep inspiration. This deep inspiration, when the child takes, air moves through a partially spasmodic glottis and it produces a whooping sound. It is called as a loud, high-pitched sound. These violent attacks of cough are precipitated by cold air, cold water, food and anxiety in the child. And often after a bout of cough, there may be post-tussive vomiting. Due to repeated such episodes, the child may develop ulcers on the frenulum of the tongue. So this paroxysmal stage is the most dramatic. So I don't have pertussis, but if I have to show you, the child will cough something like this. He will become red, suffused, not breathing, patient. It will be a very dramatic kind of cough, and suddenly after the cough, when he gets breathless, he will take a whoop. That kind of sound, inspiratory, is called as whooping cough. If you get a video question in the exam, video questions can be asked. They have been asked in the AIMS entrance in the past. Easily you can make out. So this is the typical child. It can happen at any age, but usually common in unimmunized, partially immunized children in the first 10 years of life. Violent coughing, low-grade fever, sore throat not prominent, and associated with inspiratory whoop. So what are the points that you should remember? It is characterized by violent, paroxysmal. Paroxysmal means episodic. So violent paroxysmal cough associated with inspiratory whoop. This inspiratory whoop is a loud and high-pitched sound when air moves through a spasmodic or partially closed glottis. These violent paroxysmal coughs are precipitated by cold air, cold water, food, as well as anxiety. They are associated with post-tussive vomiting, and a useful clue for MCQs, they will have ulcers on the frenulum of tongue. These ulcers are not forming due to the effect of toxin. They are forming because of the violent cough which is happening. It is causing the teeth of the child being pushed again and again violently against the frenulum of the tongue. Although there is one theory which says that presence of toxin predisposes the child to develop ulcers, but this is the predominant mechanism. This paroxysmal stage tends to last between 2 to 6 weeks. So, 2 to 6 weeks is the duration. And then third is the stage where the improvement starts happening, called as convalescent phase, convalescent stage. Convalescent phase stage, that patient tends to start improving. But dry cough which is not associated with whoop, may persist for a relatively long duration. Relative long means sometimes it can persist for as long as 2 to 3 months. So, this is the clinical spectrum of the disease. Coming to complications of pertussis, first we will have the respiratory complications. Respiratory complications will include the development of pneumonia, otitis media, there may be bronchiectasis, there may be pneumothorax because of the violent coughing, and many children will have a reactivation of tuberculosis if it was latent. Then GIT complications, because of increased recurrent violent coughing, the intra-abdominal pressure will rise, and so patient will develop hernias and rectal prolapse. Thirdly, CNS involvement can be in the form of seizures as well as encephalopathy like illness. Seizures are multifactorial, can be related to hypoxia. They can also be related to toxin getting systemically absorbed. Although seizures are mild in nature, occasional, and more related to relative hypoxia rather than the direct toxic action. And then bleeding manifestations can develop, which include epistaxis, subconjunctival hemorrhage, retinal hemorrhage, and intracranial bleeds due to the violent coughing. And finally, remember that the disease is most severe in young infants. The disease is most severe in infancy. These are the children who do not have a whoop. Whoop is not prominent, but they have recurrent episodes of apnea as well as pulmonary hypertension, and so the mortality is high as compared to older children. Nelson says children in infancy, especially those less than 6 months, have the highest mortality rates. Another point where you can just put it as a MCQ pearl, that antibodies of pertussis are not transferred from mother to child. And so, normally you know that in the first 6 months the maternal antibodies protect against a lot of bacterial and viral infections, especially bacterial infections. But this DPT, that is why you need to give DPT in 6, 10, 14 weeks. One of the reason is pertussis antibodies are not transmitted, and so they are not protective for the child. Now, coming to diagnosis of the condition. When you do blood test, first thing that you will find, the important thing you will find is that these children will have increased total leukocyte count with absolute lymphocytosis. So, very high lymphocyte count ranging as high as 10 to 15,000 per microliter. And what is the investigation of choice? Investigation of choice has been asked in NEET PG as well as AIIMS exam. Investigation of choice is culture which is taken from nasopharyngeal swab. So, you do culture of the patient, culture of the swab, that is nasopharyngeal swab. Microbiology related MCQ, we are doing in an integrated manner. The media which is used is Bordet Gangu media. So this is an MCQ. This is an MCQ. Investigation of choice may, which is the place from where culture is taken, and media is the MCQ. So this is an important thing. Finally, we come to therapy, treatment. For treatment, drug of choice, the first line therapy are the macrolides. Now there is a lot of controversy here. Which is better, azithro versus erythro? Very simple. Drug of choice, if you have to pick one, azithromycin is preferred over erythromycin. For the simple reason that first of all, erythromycin has a tendency to cause congenital pyloric stenosis, as we have discussed in GIT module. So, plus secondly, erythromycin estolate, when you give it, it needs to be given for a longer duration of 10 to 14 days, whereas azithromycin is cheaper. Single daily dose you can give. Erythromycin needs to be given in multiple doses in the day. Azithromycin single dose and 5-day course is good enough, and that is why azithromycin is now considered to be the drug of choice. And for chemoprophylaxis, in all household contacts, you need to give erythromycin or azithromycin along with booster dose of vaccination. The third important infection we will be discussing is meningococcal infections in children. Meningococcal infections are often asked in exam, but it is often missed by students. First of all, what is the etiological agent? You know the etiological agent, it is a gram-negative diplococci, which is capsulated organism called as Neisseria meningitidis. Neisseria meningitidis. There are multiple serotypes of this bacteria which are prevalent, which are based upon capsule type. They are based upon the capsule type. So, the common serotypes which are prevalent worldwide, they include type A, type B, type C, type W, 135, type Y. Among them, in the Indian context in Southeast Asia, type A is the most common, including India, whereas type B is most common in the Western countries. Overall, no comparison data exists, so they will not ask you to take side. So, this is something that you should remember. Another important thing is, for unknown reasons, the disease is twice more common in males as compared to females. And what is the mode of spread? The mode of spread is close contact or droplet route. Remember that young children and even sometimes adolescents, they carry meningococcus in the nasopharynx as carriers. Now, there is a very interesting thing to understand here. The nasopharyngeal carriage rate is much more in patients, in children who are above 1 year of age. In the first year of life, nasopharyngeal carriage is virtually absent, and that is why meningococcus is not a common cause in the first 6 months of life. So, when you talk about causes of meningitis, Neisseria meningitidis will not be among the common causes because it does not cause colonization, and so it does not cause invasive infections. Whereas, in the age group starting from 1 year of age till, if you see, up to 12-13 years, this is the time during which the nasopharyngeal carriage rate is very high. And so, you will have maximum cases of Neisseria meningitidis causing infection in that age group. So, this is an important concept that you need to remember. Now, moving to the pathogenesis of the disease. Pathogenesis is very simple. Whenever Neisseria meningitidis is present in the presence of any risk factors. What are the important risk factors that you should remember which increase the chances of invasive infection? First of all, if there is complement pathway defects. So, complement protects against Neisseria infection, particularly C5b to C9. If they are present, there is an increased risk of meningococcus. Secondly, if the patient is having therapy by a drug called as eculizumab. Where was eculizumab used? If you go back, you would remember that there is a condition called as hemolytic uremic syndrome. Atypical hemolytic uremic syndrome, we use anti-C5 monoclonal antibody called as eculizumab. Since it depletes the complement, so again eculizumab has been associated with increased risk of meningococcus. Thirdly, capsulated bacteria are removed by spleen. So if the spleen is not functioning or absent, meningococcus will happen more. So splenic abnormalities or splenectomized patient who has not received any vaccination. And thirdly, sometimes it is seen that sickle cell disease has increased risk, although the reason is not entirely clear. Finally, conditions like SLE, which cause complement depletion, have a tendency to cause increased risk of meningococcal infection. And finally, immunocompromised children. So if any of these risk factors, see, I could have just simply shown you a table of these factors, but telling you the reason always ensures that if you get a atypical question or a clinical scenario, you should get the answer correct. End of the day, not everything can be mugged up. If you know the reason behind it, it is always easy for you to remember. So if any of these risk factors are present, then Neisseria meningitidis produces a invasive infection. It gets transmitted through the bloodstream, producing meningococcemia. When it produces meningococcemia, you know that it is a gram-negative organism. Gram-negative bacteria have lipopolysaccharide, also called as endotoxin, in their cell wall. So there is a release of endotoxin, which is also called as lipopolysaccharide, which is present in the cell wall. This is the major pathogenetic mechanism, MCQ. This endotoxin produces two important things. First, it causes capillary damage leading to capillary leakage, which can cause directly shock. And secondly, it activates a component called as toll-like receptor 4, which produces an inflammatory cascade resulting in large amounts of interleukin 1, interleukin 6 and TNF alpha, producing septic shock in the patient. So septic shock can be contributed by the capillary leakage also and by this mechanism as well. So this is a very important mechanism. It has many hidden MCQs. Risk factors have been asked in exam. Lipopolysaccharide is the major pathogenic factor, that is an MCQ. Capillary leakage is seen in which common bacterial infection? This is meningococcemia. And which receptor is the primary thing which is activated in the inflammatory cascade early? That is toll-like receptor 4. All the 4 are important MCQ points. So let us talk quickly about the clinical features. When we talk about clinical features, first of all, incubation period is between 2 to 10 days. What are the types of infection which are seen? Many of these children may have a mild surface disease, where only petechiae or some localized colonization may be present. Second, children will develop acute meningococcemia, where active organism is proliferating. So these are the children who will have features of fever, toxicity, there will be development of shock, they can develop DIC, they can develop oliguria, that is renal failure, and a characteristic thing regarding meningococcemia is that these children will have petechiae or purpurae on the body. These petechiae or purpurae are due to septic embolization along with capillary damage, and they are infectious. So meningococcus can be isolated from these petechiae or purpura. If petechiae purpura are present, the patient is called as having purpura fulminans if they are present all over the body. Purpura fulminans, right? And rarely some of the patients may develop adrenal hemorrhage, which is often bilateral. If adrenal hemorrhage develops in severe meningococcemia, that is called as Waterhouse-Friderichsen syndrome. But the fortunate thing is, it is not that common as it is thought in case of children. And the third type of infection which meningococcus can produce is meningitis. Meningitis can occur alone or with active evidence of acute meningococcemia. So, the typical features of meningitis, fever, headaches, photophobia and positive Kernig and Brudzinski sign, they may be present. And fourthly, some children may develop chronic meningococcal infection. Chronic meningococcal infection will be characterized by episodic fever. In between these episodes, patient will be fine. There will be anorexia, there will be joint pains due to arthritis or arthralgia, and there will be erythema nodosum like lesions on the skin. New thing added in Nelson, chronic meningococcal infection in children occurs in those who have IPXL1 gene mutation. So, it has now been identified that children who have this gene mutation have increased risk of developing chronic meningococcal infection. It is a potential MCQ. Now, coming to investigations. In investigations, you can do blood studies, you can do latex agglutination, you can do PCR. So, isolation of the organisms is the gold standard. You can do culture, you can do latex agglutination, you can do PCR studies in the patient. And finally, if a meningococcus is present in the CSF, it may also be grown on culture. So, therapy, treatment, drug of choice is penicillin G. The dose is 3 lakh international unit per kg per day intravenously in divided doses. A useful alternative or first line therapy is IV ceftriaxone. In very young children, you can also use IV cefotaxime. Some books still talk about chloramphenicol, including Opigai, but chloramphenicol in clinical practice, frankly, in my clinical practice so far, I have never seen anybody give chloramphenicol for meningococcal infection. It is virtually not used, it is more of a theoretical thing. And the duration of this therapy, total therapy is given for 7 to 10 days. Whatever agent you are using, you give it for 7 to 10 days. And the therapy should be continued till the patient is in a simple disease, if the patient is afebrile for 3 days, and till the patient is afebrile for 5 days in meningitis. So, in case of meningitis, response is usually seen, it takes around 5 days for the patient to respond, the fever to respond. And supportive therapy for septic shock, ARDS, whatever an oliguria that is happening, that needs to be given as well. So, supportive therapy is also needed. And finally, the controversial thing here, that is chemoprophylaxis. Chemoprophylaxis includes 3 agents which can be used. I'll keep it simple. Earlier, the rifampicin was considered to be the therapy of choice, but it was found that rifampicin needs to be given every 12 hourly, plus rifampicin does not, it fails to eradicate the carrier state in many of the children, almost 15 to 20% it fails to eradicate the carrier state. So, rifampicin has now been superseded by fluoroquinolones and ceftriaxone. Young children, ciprofloxacin should be avoided. Overall, single dose ceftriaxone is now considered to be the therapy of choice. Whatever I am speaking is based upon all standard textbooks, which includes Nelson, which includes CDT Pediatrics, also things written in Harrison 20th edition. So, from entrance point of view, it is very, very important that you should remember chemoprophylaxis in meningococcal infection. So, you can remember in case of children, drug of choice is single dose intramuscular ceftriaxone. Okay. In case of single dose 125 milligram, that much is sufficient. It has almost 90 to 95% efficacy in eradicating. For children, if the age is more than 15 years, the dose becomes twice, that is 250 milligrams is the dose that you need to give in. And alternative in children are rifampicin as well as ciprofloxacin. WHO latest guidelines say that in adults, ciprofloxacin is the drug of choice, ceftriaxone being an alternative. Rifampicin is not popular anymore in case of adults. So this is regarding medicine, so I am not writing it down because we are talking only about children here. So this is regarding chemoprophylaxis. Look at the panel of these images. These panel of images are showing the characteristic features of diphtheria. As you can see in the first picture, there is a grey white pseudomembrane extending to the adjacent structures. The case can come in the form of patient having moderate grade fever along with sore throat, and the following findings were seen. As you can see, there is pseudomembrane in the patient and bull neck appearance. Bull neck appearance should be differentiated from appearance of mumps. Mumps will be due to parotid enlargement, so ear movement will happen. It will cause difficulty in opening of the mouth, and it will cause swelling which is more. It will cause a swelling which is more superior, whereas here the bull neck appearance is on the lower side. It is around the angle, it is below the angle of the jaw where this tends to develop. So this is a bull neck appearance, this is another child with bull neck appearance. So these are the visuals that you should remember for diphtheria. So this is the characteristic purpura fulminans, the petechiae purpuric rash, which is seen in a sick child with meningococcemia. So just remember this description. Toxic child, fever with all these problems. Question says splenic defect or complement defects. What is the likely diagnosis? Meningococcal infection. Acute meningococcemia is the likely diagnosis. Before we finish, there is an important MCQ pearl I want to share with you. Studies have shown that children who develop meningitis have a better outcome than those developing meningococcemia without meningitis. Now this is how the statement is written in the books. Now I'll explain in simple words. Suppose you have two kids. One kid is having acute meningococcemia alone. Second is acute meningococcemia with meningitis. Who has a better survival chance? So obviously you will say, sir, जिसमें सिर्फ meningococcemia है, because one complication is less. Wrong. Studies have shown children who have only acute meningococcemia in the absence of meningitis usually do not have a good outcome. Children who have meningococcemia with meningitis actually shows a better outcome. The reason is very simple. If the patient develops features of meningeal irritation, it means the patient's meningococcemia is not fulminant. The patient had time to localize, to not allow complications to develop. Bacteria had the time to cross the CSF and produce all the raised protein, low sugar and all these manifestations, and meningococcemia was continuing, but the patient did not die. That means the immune status is still intact, body has controlled. Any patient where meningococcemia is present without meningitis is usually considered a more fulminant infection and is found to have a higher mortality. So this can be a statement based question for your entrance exams. This finishes these important infections. Let us move towards the next infection. The next infection is scarlet fever. Scarlet fever is caused by group A beta hemolytic streptococci. That is, Streptococcus pyogenes is considered to be the most common cause. What is the age group during which scarlet fever happens? It can happen at any age, but children between the age group of 2 to 12 years are most commonly affected, but it can occur at any age. This is something that you should remember. Now, what are the classic clinical features of scarlet fever? As the name itself is saying, the fever will always be present. 4 things are always present in patient with scarlet fever. There will be fever, there will be sore throat, there will be rash, and there will be strawberry tongue. So the 4 cardinal features include fever. Second, there is sore throat, which occurs due to streptococcal pharyngitis. Thirdly, there is strawberry tongue. What is strawberry tongue? You have read about it in Kawasaki disease also. The tongue is swollen, dark pink in color, and hypertrophied prominent papillae appear as small red dots on the surface. If there is an exudate covering it, if there is a white exudate covering it, then you call it as a white strawberry tongue. If there is no exudate or if you remove it, you have a red strawberry tongue. So, strawberry tongue where hypertrophied papillae give a strawberry appearance, that will be present. And fourthly, there will be rash in the patient. Now, the important thing regarding rash that you should remember is rash usually appears 24 to 48 hours after the onset of fever. Second thing regarding rash is that it is a fine erythematous maculopapular rash which starts from the face but is more prominent on the, it spreads to the trunk, and most of the children by the time they present they have a rash on the trunk. It gives an appearance which is called as sandpaper appearance or sandpaper rash. If you look at this rash, there will be very few normal areas in between the lesions and it will be a kind of diffuse erythematous. If you look closely, you may find some unaffected areas as well. That is the appearance what we call as sandpaper like rash. So, these are the four cardinal features and it is always a non-itchy rash. Very rare patients may have some degree of discomfort or itching, but it is a non-itchy rash which is seen. So, these are the four cardinal features which are important. There is another important pointer which you will find in MCQs which is called as Pastia lines. Now, what is Pastia lines? Pastia lines are rash becoming more prominent or accentuated in the axillary creases. So, Pastia line refers to the rash of scarlet fever is accentuated, that is worsened or more prominent in the axillary skin folds. That is called as Pastia line. So, this is a very fancy word you may find in the books or in the MCQs. Now, a close differential diagnosis of scarlet fever is Kawasaki disease. Kawasaki disease is a vasculitis. There are many ways of distinguishing between the two. More details I have talked in the module on Kawasaki disease which you can go through. But Kawasaki disease will have fever lasting more than 5 days with no evidence of any response to antibiotics. Fever in these patients is not as high or as prominent as that in Kawasaki, and it shows a very good response within 24 to 48 hours of starting beta-lactam antibiotics. So, it is a responsive fever which is seen in these patients. Few patients may have other features like conjunctivitis, some may have regional lymphadenopathy, and very rarely you may find some peeling of the skin occurring, desquamation also happening. These are the features why sometimes Kawasaki disease and scarlet fever can be confused. However, in patients with scarlet fever, when you do a throat swab culture, you will always be able to identify, you will be able to isolate the organism in most cases. Now, coming to therapy, what is the treatment of choice? The drug of choice in these patients is penicillin G. So, what are the things that you should remember related to image? Look at these two images. The first one is your diffuse maculopapular sandpaper like rash which is present in these children. So, can you see a very fine rash erythematous which is present prominent on the trunks, also extended somewhat to the limbs, and this is the tongue. You can see pink small hypertrophied papillae protruding through the surface giving a strawberry appearance. This is called as a white strawberry tongue. If you remove this exudate which is deposited on the which is coating the surface of the tongue, you will find a diffusely erythematous tongue with this appearance. We call it as red strawberry tongue. So, strawberry tongue, there are two differentials, Kawasaki disease and scarlet fever. So, this finishes our discussion of scarlet fever as a small brief topic. And finally, in bacterial infections, we come to the disease called as tetanus. Now, what is the etiological agent in tetanus? Tetanus is caused by a gram-positive anaerobic bacillus called as Clostridium tetani. So, Clostridium tetani is the causative agent. What are the few things regarding Clostridium tetani that you should know? It is a gram-positive anaerobic spore forming bacillus. This is present all around us. It is commonly found in the dust, in the soil, and also sometimes in the gut of animals and humans. So, it is a common contaminant present all around us. It usually exists in adverse environment in the form of spores. Whenever hypoxic conditions are available, then the spores germinate to form vegetative cells. These vegetative cells produce a toxin called as tetanus toxin. It is a type of neurotoxin. So, there are basically two types of toxins which are produced in Clostridium tetani. We have one toxin called as tetanolysin, and second toxin is tetanospasmin. It is tetanospasmin which is responsible for most manifestations. Tetanospasmin is a type of neurotoxin. This toxin has a tendency to attach to the synaptic terminal of neuromuscular junction in motor neurons. After attaching, it enters inside the neuron and shows retrograde axonal transport. Through retrograde axonal transport, it rises and reaches the cell bodies of alpha motor neurons present in the spinal cord. After reaching this alpha motor neuron cell bodies, it moves to the inhibitory interneurons. It reaches the interneurons. Now, the normal function of interneurons in spinal cord is to release glycine and GABA. Glycine and GABA are inhibitory neurotransmitter. They are involved in relaxation of the muscle. When it reaches and affects the interneurons, it interferes with release of inhibitory neurotransmitters like GABA and glycine, and so it produces a severe type of spastic paralysis. This spastic paralysis is an irreversible paralysis. That is what produces the clinical manifestations in tetanus. If MCQ asks you, how does it interfere with release of GABA and glycine? Although it will make it a bit complicated, but from entrance point of view, this is something you should understand. Now GABA and glycine are neurotransmitters. They are stored in synaptic vesicles. Synaptic vesicle, when it fuses with the membrane, then it releases the neurotransmitter. This toxin has a light chain and a heavy chain. The light chain is the active part which prevents the fusion of these neurotransmitter containing granules with the membrane, and so GABA and glycine will not be released. As a potential MCQ high yield extra edge point, you can remember that tetanospasmin, it is mentioned in Nelson, light chain. The heavy chain is involved in only localization and movement, right? Light chain is the active component. Tetanospasmin light chain destroys a protein called as synaptobrevin, which results in interfering with release of GABA and glycine. This is the mechanism. Now, the potential MCQs which can be asked: retrograde axonal transport, this is the keyword, interneurons in spinal cord, interferes with the release of GABA and glycine, which are inhibitory neurotransmitter, and synaptobrevin is destroyed by the light chain. These are the four things that you should remember regarding the mechanism of this toxin. Now, after talking about the mechanism, let us move towards the mode of infection. Mode of infection can occur in two scenarios. In case of newborns, they can get affected if they are born to unimmunized mothers. If the mother is unimmunized, she has not passed her antibodies to the child, plus if the neonate gets exposed to poor cord care. Often you will find in rural areas a proper cord care is not there, or they apply cow dung or sometimes even mud on the spinal cord stump. It is a cultural practice in some parts of the country, and that can introduce tetanus spores producing neonatal tetanus. In other patients, non-neonatal age, usually wound contamination is the common mechanism by which tetanus spores enter inside the system. Now coming to the types of clinical types of tetanus. The first common form is known as generalized tetanus. Generalized tetanus has an incubation period between 2 to 14 days with an average of around 8 days. Generalized tetanus, the first sign of generalized tetanus is spasm of the masseter muscles bilaterally producing trismus. Trismus is also called as lockjaw. The old name of tetanus is actually lockjaw, which occurs due to spasm of masseter muscles. After this, the patient will also start to have headache, dysphagia, there will be difficulty in speaking, and the patient may have fever. Important thing to remember, fever is not due to the organism itself. Fever occurs due to spasm occurring in the muscles. So, it may sometimes be present. Gradually, as the disease progresses, there are two important things that you should remember. Many of these patients tend to develop rhizus sardonicus. What is rhizus sardonicus? Bilaterally, there will be spasm of the muscles at the angle of the mouth and the upper part of neck. So, the mouth will be opened like this. This type of appearance is called as rhizus sardonicus. So, open mouth with the angles of the mouth, jaw are being pulled apart, that is rhizus sardonicus. And secondly, some of these patients may develop a posture called as opisthotonous posturing, hyperextended, exaggerated extension in the back. In the severe forms, you may even find only the head and heel touching, the entire body is like a dhanush or a bow. So, there will be intense hyperextension occurring of the back. Along with these, there may be interspersed painful muscle spasms, which are episodic. During this time, episodes of choking may also develop, and they are often precipitated by noise, food or water, and they are associated with autonomic nervous system dysfunction also. So, tachycardia, bradycardia may sometimes be seen. So, plus minus they may be present. The second common form is neonatal tetanus. In neonatal form of tetanus, the disease always presents between 3 to 12 days of life. Nelson is very clear, it never presents in first 48 hours of life or beyond 2 weeks. This is the time during which neonatal tetanus will develop. The first sign of neonatal tetanus is there will be excessive crying by the child, unexplained crying, following which the child will develop feeding difficulties. The child will keep an open mouth and there will be progressive paralysis in the patient. And the third rare form, which is also a mild form, is localized tetanus. However, localized tetanus is usually mild but can be severe if it progresses to generalized illness or if the patient develops cephalic tetanus, that is head and neck involvement. Cephalic tetanus is characterized by bulbar palsy, and so it has a very poor outcome. Now, coming to the management of these patients. For the purpose of management, first of all, antitoxin therapy is mandatory. Antitoxin cannot dislodge the toxin which is already attached to the neurons, but it can slow down the progression of the disease. Along with antitoxin, the usual antitoxin therapy needed is in the dose of 500 to 1000 international units intramuscularly. Sometimes as high as 3500 international units can also be given under controlled circumstances. Second, you need to give antibiotics to stop the proliferation of the bacteria, and so that toxin production does not happen. The drug of choice in these patients is penicillin G. Alternatives can include metronidazole because it is an anaerobic infection, and you can also use erythromycin. Some patients recommend tetracycline also, but that is no longer clinically useful. And then you need to give supportive therapy. In supportive therapy for muscle spasms, you need to give diazepam, which is the drug of choice. You can give IV bolus or you can start as an infusion. If diazepam fails, you need to consider pancuronium as well. But in pancuronium, always intubate the child. And secondly, you need to ensure hydration, nutrition, and maintain airway. Airway management is needed. If you find choking episodes are causing gasping efforts or recurrent spasm of laryngeal muscles are happening, you need to intubate or even do tracheostomy in the patient as well. Mortality in these children is high. It is found that generalized tetanus usually has a mortality in the range of around 30 to 35% in case of Western countries and about 50% in case of India. Whereas neonatal tetanus has a mortality in the range of 90%. But the good thing is, potential PSM related MCQ, India is neonatal and pregnant female, that is it's a part of the perinatal illness. So, India is neonatal tetanus free since 2015. And if for those who are thinking those people who survive and those who recover, how does the recovery happen? Recovery happens by sprouting of new nerve fibers which take the place of these old existing fibers. But the recovery is often incomplete and some deficit or paralysis may always be left behind. Cause of death is usually related to respiratory involvement, either spasm of the respiratory muscle leading to choking or paralysis of the respiratory muscles leading to absence of breathing is the cause of death. So, this finishes our discussion of important bacterial infections in an integrated conceptual manner.